This lecture, titled Space Gaining, is for the 5th grade dental students at Al-Rafidin University College, given by Dr.Nadia, a lecturer and a specialist orthodontist. The objective of this lecture is to know or to have an idea about the definition of space gaining and to discuss the different methods used for space gaining, including the detailed procedure and the advantages and disadvantages of each method. So space gaining is as simple as a way of creating a space in the dental arch that is usually required in orthodontics to correct certain types or features of malocclusion, such as crowding, overjet reduction, leveling of the curve of sphere, or correction of the incisor inclination and angulation. We have different ways to create a space in the dental arch, but the correct means of obtaining the required space in a given case should be decided usually after careful examination and model analysis. So as we said, we have different methods of gaining space, including proximal stripping, expansion, extraction of certain teeth, distalization of molars, uprightening of molars, derotation of posterior teeth, and proclination of anterior. So we will start by the proximal stripping. We have different synonyms for the stripping, including slicing, reproximation, grinding, or slenderization of tooth. It can be defined as a method by which the proximal surfaces of the tooth are stripped or disked to reduce the mesiodistal width of the tooth. So it's one of the routinely used methods of gaining space in cases where mild crowding or space deficiency or minimal arch length tooth material discrepancy of less than 2 to 3 mm is present. However, it should be done carefully to prevent the dental caries and the dentine hypersensitivity. So the main indications for the proximal stripping are as follows. Most commonly, they are used to relieve the mandibular anterior crowding and to some extent in the maxillary anterior segments. And when we do a space analysis, as we have taken in the last lecture, and the space analysis show a discrepancy of mild crowding less than 3 mm, or when we do a Bolton's analysis and we show a discrepancy of mild tooth material excess. Like it is contraindicated to do the stripping in patients with high risk of dental caries, or in young patients with large pulp chamber, as we can see here from this periapical radiograph, or the patient have a proximal caries in the teeth that are going to be sliced, or patients with a severely attrition or severely attrited teeth. The advantages of the proximal stripping that it is very successful in avoiding extraction in the borderline cases. Furthermore, it establishes favorable overjet and overbite relationship. It prevents the rotation of the teeth and gives more stable result. On the flip side, the disadvantages are many, so as the teeth sensitivity, the altered morphology of teeth due to improper stripping, the increased caries susceptibility, and the food. So the stripping should be done after careful diagnosis, depending on the model analysis and the periapical radiograph. The selection of proximal stripping as a way of gaining space depends on the amount of space required. The model analysis using orthodontic study models should be done to evaluate the usefulness of proximal stripping. So we should do the arch perimeter analysis that we have discussed in the last lecture for the maxillary arch, and the Nance caries analysis for the mandibular arch, and the Bolton's analysis to see the extent of tooth material excess. Furthermore, we should do the intraoral radiograph or periapical radiograph to evaluate the pulp chamber, the size of the pulp chamber, and the caries of the teeth that are going to be sliced and the teeth that are adjacent to them, and the enamel thickness. Procedure of proximal stripping are usually simple. They can be localized, where the stripping is performed only for a few teeth, especially the upper or the lower anteriors, or generalized when the stripping is carried out for all the teeth. But care should be taken that not more than half the thickness of enamel is reduced from a side of the tooth. The proximal stripping can be done using any one of the followings, like using the abrasive strips. Those abrasive strips can be single-sided when they are used to reduce the proximal surface of either the mesial or the distal side of the tooth, or can be double-sided abrasive strip when the intention is the reduction of two teeth, the distal side of one tooth and the mesial surface of the adjacent tooth. Or the strippings can be done by using a long, thin, tapered fissure bare, or the safe-sided diamond disc, as we can see from this picture. The abrasive strip can be used by performed. The abrasive strip can be held by using a holder, or by the operator hands, or by the needle. So this video will illustrate how the proximal stripping is usually performed. This is the abrasive strip held by the holder. The back and forth movement are going to reduce the enamel thickness. As we said, we should take less than half the thickness of the enamel. After reduction of the teeth, the number of the teeth is usually decided after the model analysis. We will create a space that is enough to align the teeth, and in the mild cases there will be no need for extraction. But after performing the stripping, a strict oral hygiene instructions should be given to the patient, and a fluoride application should be done to reduce the susceptibility of the caries. The second way of creating a space is by using the arch expansion. The arch expansion can be slow or rapid, can be removable or fixed. Let us start with the slow arch expansion that can be produced by using different types of orthodontic appliances. Some of them are removable, others are fixed. Their effect can be skeletal or dental depending on the patient age. If those devices were used in the primary or early mixed dentition patient, the mid-palatine suture are not of use yet. So any low forces can open the mid-palatine suture, and their effect will be skeletal as well as dental. But if we are using those devices in an older patient, like for instance a patient in the late mixed dentition or an adult patient in which the mid-palatine suture have been fused, those forces will not be enough to open the suture, and so their effect will be dentoalveolar expansion rather than skeletal. The slow expansion devices, as we said, can be removable or fixed. For the removable, the most commonly used are those removable appliances with a jack screw, as we can see here from this picture. It consists from an acrylic base plate with a good retention means by incorporating an Adam clasp on the 6 and 4, and the jack screw will be situated in the middle. The acrylic will be splitted into two halves, and opening the jack screw will push the two halves apart from each other, and so it will produce force on the teeth and the bone to split them apart or push them laterally, and we will get the arch expansion. So the jack screw will have a hole in the middle, and we will have an arrow mark. The patient will be given a key, just like this. The key will be entered into the hole, and the patient will be asked to turn the hole with the direction of the arrow. In the slow expansion devices, the patient will be asked to turn the key twice per week. Each turn of the screw will give us 0.25 millimeter. So in a week we will have 0.5 millimeter. And in a month we will get 2 millimeter of space. 1 millimeter will go to each half of the maxilla, which is the optimum rate of teeth movement. The other removable appliance, expansion appliance, is the coffin spring, which consists of a stainless steel omega-shaped wire incorporated inside the acrylic, usually activated by pulling the two sides apart manually, or can be activated by using a plier by bending the omega loop at the center or the base of the wire. The fixed expansion devices are so many, but the commonly used are the quad helix and the W arch. The quad helix, from its name, the quad means four and the helix means coils. So from its name, it consists of four coils, two anteriorly located and two posteriorly located. By opening the two helices, the two anteriorly positioned helices, we will get a posterior expansion. And by opening the posterior helices, we will get an anterior expansion. It has many advantages, like it can be used in patients with with a bad oral habits like the thumb sucking. Those anterior two helices will act as a reminder, and the quad helix will also expand the maxilla. Also, it can be used to provide a differential expansion, like expanding the right side more than the left side, have a more anterior expansion than the posterior. The other fixed orthodontic appliance is the W arch. The W arch is in the principle is just like the quad helix, but doesn't have helices or coils. It is a W-shaped stainless steel wire, also can produce of anterior and posterior expansion, and also you can get a differential expansion, like having more right side expansion than the left side, or more anterior than posterior expansion. Now for the rapid maxillary expansion devices, usually it is not recommended to use those devices in a small age patient because their side effects can be so many, and their main indication are those late teens patients where the mid-palatine suture has started to fuse together, and we need to make a skeletal effect rather than expansion by dental movement. So if we have a patient in the late mixed dentition age, or if we have a cleft patient and we need to expand the maxilla by stretching the scar tissue, we are going to use the rapid maxillary expansion devices. And in those cases, the patient will be asked to open the expander twice per day to have about 0.25 to 0.5 millimeter of space per day for an active treatment of 2 weeks. After the 2 weeks, the patient will not open the screw anymore, but it will be held in place just like a retainer and allow the relapse to happen. In those patients, when the expansion occurs, usually we can notice that we will have a median diastema or a space between the two centrals. Okay. The method of creating space is by extraction of teeth. Sometimes the only choice to relieve the crowding is by extracting certain teeth to align the others, especially in those crowded arch due to the teeth size arch length discrepancies. Or sometimes we need to extract the teeth because they are so badly positioned that their alignment is impossible. The most commonly extracted tooth to gain space during orthodontic management is the first premolars, because they are situated at the center of each quadrant, so the space that is created by their removal can be used to relieve both the crowding in the anterior or posterior segments of the arch. The other method of creating space is by distalization of molar. So it is the procedure where the molars are moved posteriorly by using removable or fixed intraoral orthodontic appliances, or sometimes by using an extraoral orthopedic appliances just like the headgear. But in general, the best time for molar distalization is during the mixed dentition period before the eruption of the second permanent molar, so we can get more space and less resistance to the sixes movement. And this method usually have many advantages, such as we can avoid the extraction of teeth, and it prevents the arch collapse. And devices, as we said before, for distalizing the molars, such as the removable appliance with a screw incorporated in it for teeth distalization, or we have the fixed appliance with the open coil spring, or we have the pendulum appliance, as we can see here, or the lip bumper that can produce distalization of molar and anterior tipping of the lower anteriors, or the headgear, which is an orthopedic appliance that is located extraorally. The other way of creating space is by uprightening the molars. The extraction of permanent second premolar or early loss of deciduous second molar can cause mesial drifting of the molar inside the extraction side. The tilted molars usually occupy much greater space, resulting in a crowding in the arch. So gaining the space and relief of the crowding can be achieved by uprightening the tilted molar. That can be done using the space gainer or various screw appliances or lip bumper. So this video will illustrate what have been said before. As we can see here, this is a case where we have a mesial tilt of the 6, mainly as we said before due to early extraction of the deciduous molars. So we will have a mesial tilt and we will have a reduction in the space available for the eruption of the 5. So the way of gaining space will be used by using a band and a pushing coil attached to it or soldered to it. The band will be cemented to the 6 and the pushing coil will open the space by pushing the molar posteriorly or uprightening the molars, as we can see here. So we will create more space and the 5 can erupt without any problem. The other way of creating space is by derotation of posterior teeth. As you may know that the rotated posterior teeth will occupy larger space and result in crowding in the arch. The correction of the rotated posterior teeth will not only help in relieving the crowding, but also it will reduce and prevent the development of dental caries and periodontal diseases by reducing the food impaction. Usually, the correction of the rotated posterior teeth is best done by using the fixed appliance, by using a couple force system. A couple force system means that we are going to have two forces equal in magnitude but opposite in the direction, just like we can see here from these pictures. We will have a force that is buccally situated and will pull the tooth in one direction, and another force will be located palatal and will pull the tooth in an opposite direction. Also, if the rotated tooth was less than 90 degree rotated, it can be corrected by using a removable appliance. The last way of creating space is by proclination of anterior teeth, including the upper or the lower teeth. But we have to keep in mind that proclination of the anterior teeth should not affect the patient profile, which means that those teeth should already be retroclined so that proclining them will not moving them out of the neutral zone. So our result will be stable. Any of the proclining spring can be used, such as the Z-spring or the recurve Z-spring, the screws, or the fixed appliances if more complicated problem is present. This is the end of the lecture. Thank you for your listening.